Greetings, everybody, on behalf of Bombay Orthopaedic Society. Bombay Orthopaedic Society is one of the oldest societies in India, and WIROC is its annual conference. This is the 56th WIROC, and this year we have labeled it as WIROC Global, where we have invited societies across the globe. And we are happy to inform you that more than 70 societies are participating at WIROC Global. I really thank SLARD for participating at WIROC Global on behalf of my president, Dr. Sangeet Gawale, and Dr. Vishal Kundani, my co-organizing secretary, and the entire BOS Executive Council. I thank you again and welcome you for WIROC Global.
Okay, so hello everyone. Welcome to this session. We will be talking about the use of orthobiologics in knee injuries. Thanks to WIROC Global for this invitation in collaboration with SLARD. For the next hour, we will be reviewing some of the indications, the how, when, and why of orthobiologics. It's an honor for me to chair this panel of friends and colleagues, renowned surgeons, opinion leaders that need no further presentation, and they will share their experiences and thoughts in a case-based discussion. So from Colombia, we have Dr. Juan Pablo Martinez. From Argentina, Dr. Franco de la Vedova. From Brazil, Dr. Fabiano Kupsek. And from India, Dr. Sasinder Shanmugasundaram, Dr. Santosh Shanand, and Dr. Manit Anora. Sorry for my pronunciation. And okay, so first as an introduction, when we say orthobiologics, we refer to biological substances that aid in the treatment of musculoskeletal injuries. This includes from bone grafts to autologous blood derivates, platelet-rich plasma, bone marrow aspirates, and different lineages of mesenchymal cells that have different degrees of manipulation. The evidence available so far does not provide a clear picture regarding the efficacy of most of the products that are used in the knee, and there is still room for improvement regarding standardization, protocols of administration, and more high-quality control studies are needed to determine the true efficacy. So this being said, orthobiologics have gained increased attention in our field and are extensively used around the world to aid in the healing of injuries and alleviate symptoms of knee pathologies. So let's get started with our first case to learn from the treatment strategies chosen by our panelists. So this is a 42-year-old male amateur tennis player, very active patient, that when he was 30 years old, he underwent an ACL reconstruction. A 35-year-old, an ACL revision, plus a partial meniscectomy of both medial and lateral meniscus. And after that, 2 years later, an OATS of the lateral femoral condyle. As you can see in the x-rays, we have already a tricompartmental moderate diffuse osteoarthritis. This is the axis of the patient that's almost neutral. Patient has diffuse pain, intermittent swelling, no catching, blocking, or giving away of the knee. The knee is stable at examination, has good muscular trophism, complete range of motion, but diffuse pain in both joint lines and patellofemoral joints. MRI confirms same findings. We can see that the blast is intact, but there's diffuse osteoarthritis in this very young and active patient. So we've seen this patient for 2 years now. He has gained normal weight, undergone more than 40 sessions of physiotherapy, and 2 injections of corticosteroids and hyaluronic acid injections separated by a year or so, with only partial remission of the symptoms that very shortly come back and the patient is unable to practice tennis. So let's start with a short round of questions, a yes and no answer from all of our panel. So the question is, would you offer an orthobiologic injection to this patient? And if your answer is yes, which one would be your choice? So let's start with Dr. Santosh.
Yeah, I would frankly, in my practice, I don't offer for such kind of patients in this situation. So my answer here is no orthobiologics at this stage.
So you would probably just stick with exercise injections and probably early knee replacements.
Correct, and probably look at why he is going on to develop this, reassess the stability, activity modifications, So for this, I'm not really sure. Still, gives him a good result, or would he be back to playing tennis with the options available here in my practice?
Dr. Mani, do you agree? Would you do something different?
So I get these sort of players routinely in my practice. So the place where I'm in North India, I basically get all these players that are wrestlers. They play kabaddi, which is a local sport here. A lot of footballers, a lot of cricketers, and they typically come in with this sort of picture anyways, minus the OATS LFC of the condyle. So we're really stuck when it comes to these problems because our options are so narrow with what we can offer them. So they've got tricompartmental arthritis that takes out HDO. It's too early to do a transplant or a replacement procedure. So what's left is hyaluronic acid injections. You've already given a couple of them. You've rehabbed him, obviously. He's not getting better. On the previous MRI, that graft doesn't look that great to begin with. So there's some stranding there in the graft as well. So I mean, for him, probably what I'd do is I'll put him into a functional brace, rehab him, and then you can offer PRP. But when the arthritis is so bad, once they've already had a couple of hyaluronic acid injections, I've typically found it really doesn't make that much of a difference injecting them with PRP. So the outcomes, if you follow them on the IKDC and Lyson scores, they're not that great after PRP injections in such patients. So the mainstay really is just pulling them out, trying to get them across 45, 50, so you can go ahead with your definitive procedure.
Okay, and Dr. Franco de la Vedova, do you agree with these? Would you add something else?
Yes, I think this patient is not a candidate for osteotomy. In this patient, we use PRP for treat the symptoms of the patient, change the sport activity, and manage the law of training of this patient, and just wait and treat the symptoms with PRP, 3 injections separately with a month each one. And if not, we can do sometimes when this does not okay, bone marrow aspirator or concentrated.
Perfect. And when you do PRP, do you care if it's low or rich in leukocytes? Do you think this is a difference?
Yes. It depends if you have a lot of fluid or inflammatory reaction in the knee. You have to take care in put leukocyte rich PRP. We in the knee, in the joints in general, with leukocyte poor PRP.
Perfect, thanks. And Juan Pablo, what would be your choice here? Would you go with conservative treatment or do you use any biologics?
So as a surgeon, you always want to try and see if there's something to do, but I agree that the osteotomy won't make a difference here. And I noticed that the lateral meniscus was like insufficient, but I don't think that that's the main problem, and I don't think that would matter either. So I think that this is a very good indication for PRP. I think it's one of the best quality of evidence you have. It's for knee arthritis and for tennis elbow. So I think I agree with Franco that leukocyte poor PRP would be a good alternative, and also we have the BMAC as another option. I think that you also have a difference in studies between hyaluronic acid and PRP. So I think that there's something that can be done with that, and maybe take this patient above the 50 years old to do a knee arthroplasty.
Yeah, try to win some time. And Juan Pablo, why do you choose sometimes PRP or bone marrow aspirates? What patients do you feel are better candidates to one or the other?
Well, I think it's more like matter of cost. I think that there are both good choices. I think you have better quality of evidence for PRP right now, but I think that BMAC, it's gonna be something that we have to watch out in future, because biologically it makes sense that it would help.
Perfect. Dr. Kupcic, would you do something else? Do you agree with PRP or bone marrow or conservative treatment?
Yeah, but first of all, I agree with your treatment in this young patient with psoriasis, osteoarthritis. But according to Brazilian laws, we can't use routinely PRP or BMAC. So what can I do here is to use microfragment adipose tissue like lipogenes. So in this patient, when you treat in the right way, hyaluronic acid injections, but the pain persists. So I think it's lipogenes is a good option. I have some patients with good results.
Great, thanks. And Dr. Sassender, what would be your treatment option here?
Yeah, hi. We are dealing with a young amateur male with global arthritis, not a focal arthritis. So my direction will be in terms of an injectable orthobiologic treatment. And among the two, I would like to do a bone marrow aspirate concentrate, given the chances of providing kind of mesenchymal cells for repairing the cartilage as much as possible. But I would definitely want the patient of poor prognosis because his lateral meniscus is not great. However, the alignment looks okay. So at present, the best chances appear to be with bone marrow aspirate concentrate, a single dose. Yeah.
Great. Thanks to all. So as what happens always in orthobiologics discussions, or these cases that are difficult to approach, we are all looking for different treatments, and this is the difficult of standardization. So, well, this case, it's a nightmare. We all see these patients at the office. It's difficult to live up to the expectations of the patients, but our treatment of choice is also adding PRP after we have tried all conservative treatment strategies as a mainstay first. Okay, so now we'll go to case 2, but just a quick question, like for the ones that were using PRP, do you still offer it as a treatment strategy in arthrosis if the patient, instead of having 40 or 50, it has late 60s or 70s? Do you still put in your arsenal of treatment biologics when it's a patient that could go right away to the knee replacement? Or you try to win some time always, even if the patient is late 60s or 70 years old? Dr. Manet, would you use them if it's an older patient?
I think it depends on the stage of arthritis as well. So if they're 60 plus and they've got low grade arthritis, then yes, we can offer them a PRP, and I do offer them PRP. But once they're, stage 3, stage 4, I think it has a really low role to play. And you're already plus 60, you're in our zone for surgery. So yeah, so then we back off it.
I agree. Juan Pablo, what do you think about it?
I think it's a matter about what the patient wants, because sometimes we think we need a knee arthroplasty right now, but they don't want it. So in those cases, I think it might be useful, but it's more about the patient.
Yeah, I agree. It's always about leveling the expectations, right? Great. So let's go to the second case to see if there's more consensus. So this is a 13-year-old girl, active, that has a patellar OCD, as you can see there in the images. This case is courtesy of Dr. Juan Pablo Martinez. So we will see his opinion at the end, so he doesn't make a spoiler. So she's underwent 1 year of failed conservative treatment and persists with pain in daily activities, intermittent swelling, and sports dropout because of the persistent pain. So their doctor decides surgery. So this is how the lesion looks under the scope and after debridement. So with this lesion of the patella that it's around, I would say 9 times 16 millimeters approximately, exposing subchondral bone from an OCD injury, what would be your treatment of choice, Dr. Santos?
Yeah, OCD, first I would assess how much of bone defect is there, but seeing the MRI, I don't see much of a bone defect. It's more of a grade 4 cartilage defect. So I wouldn't want to reconstruct with the bone over there. So just options we have over here are limited. So I would, the ACI or BMAC are the choices. Given the options to the patient, would they prefer a two-stage procedure or a single-stage procedure? And I would give them the options to choose. So if it's an ACI, it's going to be two-staged arthrograft and then do a second-stage procedure. If it's a single-stage procedure, go for a BMAC. BMAC with a cell gel. That's the scaffold we have available in the market here. We do not have other scaffolds over here. And the procedure as such, I would prefer doing arthroscopic prone position scopy. I've done a few of them. So as we are using a cell gel, we need gravity. We can do it anti-gravity, but with gravity, the results with dry scopy, a prone scopy where the patella is the dependent position. Then we can inject the gel in a dry scopy position, and that would be my procedure choice. And do assess for the patella, TTTG and other high loading patella, and look into any additional unloading procedures required or not.
Perfect. Yeah, prone arthroscope is great for these cases. I agree too. So Dr. Sassender, do you agree with that? What would be your approach in this case?
Yeah, we are dealing with a 13-year young patient with patellar focal chondral lesion, which is far different in the management from a diffuse chondral injury or arthritis. So I'll just make sure the alignment of the limb and also the patellofemoral tracking is fine, or rehab the patient. And for such a lesion, I will definitely go ahead with a bone marrow aspirate concentrate. PRP is not a great option for a focal chondral lesion in a young patient. I prefer PRP for pain relief for early arthritis. That is a global chondral lesion.
And Sassender, what scaffold do you use for the bone marrow aspirate?
Okay, we have a fibrin gel along with the bone marrow aspirate in a double barrel syringe. In my hands, I do a mini open incision and something similar to this. I'm not experienced in prone arthroscopy, and I don't prefer oats for the patella.
Great. Juan Pablo, do you think this case would benefit from an oats or an allo plaque? Or do you think biologic options are best alternative in this case?
The thing with the oats that I don't like that much is that you have the problem with the depth of the cartilage in the patella is different from that of the femur. So you never know what to do if you leave the cartilage to the level, but then you have the bone. So that's what I don't like. But I think that allograft, fresh allografts would be a great option for this case too. Yeah. I
agree. Fabiano, what do you think?
First of all, in patellofemoral joint, I always analyze risk factors like TTTG, patella height, and all of the trocar dysplasia before I decide what treatment will be better, if there are any signs of instability and partial reconstruction. But I think in this case, it's everything okay. Yeah. So a focal chondral lesion or OCD, at this age, a young patient, I prefer to treat biologically with membrane collage, like chondrocyte that I have here in Brazil, It's a good way. So if you have a bone defect, I feel with bone graft, you can take off proximal tibia. So and fix the membrane, the scaffold with fibrin glue. So I think my results, it's a good one. I don't think odds in the middle of the patella cartilage sulfate, it's a good place. Maybe in the medial facet, I think it's a good idea.
Agree.
And don't use BMAC. Sometimes I can feel with a piece of cartilage, can insert cartilage. I think at this age, it's a good idea. So.
Yeah, and fresh plaques also have the problem of the cost and the availability. That's also sometimes a bit difficult. Franco, what would be your choice here? Do you agree with the rest?
Yes, I agree with Dr. Sassinger and Fabiano in taking care in the alignment and instability on this patella. Unluckily, here in Argentina, we don't have collagen scaffold, so we have to do some allograft there or what. If I plug in there some BMAC, we can take it from the proximal tibia.
Good. Okay, so we're going to show what happened next. So this is the look of the lesion. So what Dr. Martinez did was bone marrow aspirate directly from the distal femur that was exposed. And let's see if this videos run. There you have. So this is like minced fragments of cartilage from the debridement of the lesion, the ones that had better microscopic aspect. So they fill it with the cartilage. They use the bone marrow aspirate and a yellow fast membrane sticked with fibrin glue. And you will see this is the final result. Here they're applying the glue. And turns out very nicely, as you can see there. So Juan Pablo, tell us more about the follow-up that you do with these patients. So do you just follow up them clinically? Do you use images? So
first, I think that there were some things that the other panelists said that are very important about the alignment, about the stability. I think that that's very important. In this case, it was just an OCD injury. I did an MRI for this patient 6 months after, and it showed very nice filling of the cartilage defect, and she she's trying to get back to sports, and we have like 10 months now of follow-up. I allowed them a partial weight bearing since the first day, and for 1 week I tried to use a brace, but just for walking, and then try to begin movement since the first day, and that's how we have her.
Great case. Thank you very much. So does anyone want to comment something else or have any question? Just feel free to raise your hand in that case. If not, we can go ahead and move to our third case. Okay, so this is a 23-year-old first division professional soccer. This is a case from Dr. Julio Espinosa. This is the head coach of one of the best teams of soccer in Chile. In Chile, we're huge fans of soccer. So this was a national topic. This player, they had 4 months of anterior knee pain, unresponsive to physiotherapy. And then you can see the ultrasound that there were tendinosic changes in the proximal portion of the tendon, the patellar tendon. This is the MRI that confirms same findings. And in spite of very high quality rehabilitation with a multidisciplinary team, there had been no answers from this. The patient had also tried shock waves, but pain was persistent So what would be, Dr. Manet, your approach in these cases? How long can we wait?
Yeah, I would say 3 months. So they're already at 4 months post. They've done their trial of conservative treatment with physiotherapy. And now that your MRI and your ultrasound confirm what you've been suspecting about the patellar tendon, I would go ahead and give them a PRP, because all these players, for players, it's all about when can they get back to the game. So when can they return to sport? They don't care about anything else. They just want to know that, okay, doc, when am I going to be back playing for my team? And that's all the coach wants as well. That's all the nation wants as well, apparently. So you can help facilitate that, I think, by giving them an ultrasound guided injection of PRP, which will go directly into that hypoechoic area. And I would also put them into an anterior offloading brace, and then rehab them after that. And I think that just with that itself, it's important to take them out of the activity for a while, because this is an activity-induced injury. So you take them out and do all of this stuff and do the rehab, and then slowly ramp up and get them back into the sport. So you're targeting about 3 months more for them to return to high-level sports.
And the coach will want to kill you. Okay, and the PRP, you use only one injection, right? You don't repeat it?
No, so 3 injections spaced a week apart.
Okay,
and,
perfect.
I think in these cases, a leukocyte-rich concentrate is really helpful to stimulate healing.
Perfect. And Dr. Sassender, would you agree with using PRP in this case?
Yeah, I agree with most of what Dr. Manet said. He's a good candidate for PRP injection. Being 4 months down the lane, I would possibly wait not more than 6 weeks in the presence of rigorous physical therapy. I'm not sure about the number of PRP injections, possibly 1 here, because the amount of tendinosis is not very severe. But I don't have a lot of evidence on this. Maybe 1 PRP injection and wait and watch.
Great. And Dr. Della that you treat a lot of rugby players that are similar to soccer. What would be your approach in this case?
Yes, I think in this case, we have to take care of 2 main problems. One is the training load management there, and trying to correct all the biomechanic deficits that these athletes always have. Meanwhile, we can do some strength and isometric and eccentric strength in this tendon, but it is failed is going to depend in which part of the season you are, and if you can stop these athletes, or if the athlete is decreasing in the performance, this is the time for doing something else and stop him. And if we are going to do something, you just tried shockwaves with no response. I think that PRP, ultrasound guide, PRP, leukocyte-rich is an option. I don't know how many injections I'm going to do in this patient. It's going to depend in the response. I will do as less as possible to allow the patient come back to the game. I want to say that it's very important to do these injections with ultrasound guidance, because you are going to inject in the part of the tendon that is ill, and you can see the tendinopathy, and you can see where the power Doppler show you where's the main injury. And beside that, you can see how the fluid goes into the tendon, and you can feel how these fluids go into the tendon, if it's this rupture or something different.
Great. And Franco, do you follow them up with images, or you just stick to clinical response?
I do the ultrasound by myself, so I follow it on in all the visits to the office, but it's not necessary. It's important to look how the patient is doing. And I'm very close trying load management.
Sorry. Perfect. Sasinder, do you want to ask something or comment?
Yeah, I'd like to ask everyone, how do you decide which patients are good candidates for shockwave therapy?
Does any of you use shockwave therapy as a routine in the treatment of these patients? Like, would be part of your classic therapeutical management?
Yeah,
Pablo?
yeah. For me, shockwave therapy, it's a very good option for this patient because physical therapy is not working. Physical therapy usually works for this type of tendinopathies, but my second line of treatment is usually shockwave therapy because it's non-invasive and it's easy to do, and our insurance actually covers shockwave therapy. PRP is not covered, so for me it would be like the next step. How to choose the patient was Sasi question, right? I think it's the ones that are not responding and that you are they are following your instructions, they are decreasing load, they are doing physical therapy. I think that would be the next step for me.
Okay, I'm sorry.
Great, thanks, Juan Pablo.
I'm sorry. Is it essential that you have to have evidence of calcification to think about shockwave therapy, or even tendinosis patients respond very well to shockwave?
So your question was partial injury versus tendinosis?
No. Is it essential that the patient should be having some evidence of calcification, or even just tendinosis response to shockwave?
Okay, so in rotator cuff, it usually it's better when they have these calcifications. They respond better, but here it really doesn't really matter much for me. I use it even if it's only tendinosis.
Okay, great.
Thanks, Juan Pablo. I agree. Franco, do you want to add something else?
Yes, I think that shockwaves is a good option. Maybe before PRP, if you don't want to stop the athletes. And you have two different protocols for shockwave. You can do some protocol for more analgesic treatment, and you have another for more regenerative one. So most of the time I use the analgesic protocol, and it goes okay for the patients.
And if you're using shockwaves, how long are you waiting? As I understand, you use first line physiotherapy, second line to unresponsive shockwave, and then you would go for as a third line strategy with biologics, PRP probably. So how long do you wait in between one and the other?
I wait to the time where in the season that the athletes can stop, or when the athletes decrease the performance.
Perfect, thanks. And Fabiano, as you mentioned, in Brazil, you don't have like routine access to platelet-rich plasma. What would be your choice after failed shockwaves and physiotherapy in this case?
What I can do here, it's hyaluronic acid injection, ultrasound guides. We have hyaluronic acid specific for tendon, like spots vis. So I have a few cases, so there is no many experience in this injection. There are a few studies around the world, but I think in this case, it probably will be my choice now.
And Fabiano, I know that you do a lot of research regarding umbilical cord derived mesenchymal cells. Do you use them also for tendinopathies?
Not yet. My research with umbilical cord mesenchymal stem cells is only for cartilage defects and osteoarthritis. So not yet.
Perfect. And regarding that, what would you think are the pros and cons of obtaining mesenchymal cells from umbilical cord versus fat or versus bone marrow?
It's a great discussion. I think it's we can do only one step surgery. We can expand in a lot of amount of cells. We have the benefits of the number, how many cells. So we have quality of these cells. There is no problem with mother and the childhood. So it's a great, for me, it's the best source of its mesenchymal stem cells.
Thanks, great. And Dr. Santos, would you add something else to this case?
Yeah, so some cases would have a diffuse tendinosis and some would be a focal nodule. Mostly it will be right at the center. In spite of, I agree with all the faculty where in spite of giving even 3 doses of PRP, they do come with recurrence, and that fibrous nodule right in the center. I mean, we've done a couple of excisions like harvesting a PTB graft, excise the central part of the tendon where the fibrous nodule, which is of course initially do a ultrasound and mark the area, and they've done that, which is resistance to, which has resistance to these management methods.
Perfect. Sasindir, you want to add something?
Yeah, this question is for Dr. Fabiano. I just want to ask, in your using umbilical, it's not related to this question, sorry. When you use umbilical cord stem cells, how do you deal with the reaction you match for HLA and ABO? Is there anything else you should be concerned about?
Yeah, we have a lab that control a lot of tests, so we can perform the injection with total security. So we don't have adverse events. So we have been this research about 5 years, and no adverse events.
Thanks. Okay, so let's see what happens with this case. So as we all mentioned here, we did the PRP injections, as you can see there, ultrasound guided. And fortunately for the soccer and all the fans, had an excellent response. You can see there the pre-PRP ultrasound and post. There's dramatic imagenological changes, but the most important was the patient was clinically free of pain and able to return to sports very soon. Okay, so let's go to the fourth case. So this is a probably difficult scenario that you have all faced. So this is a 29-year-old professional basketball player. This case is courtesy of Dr. Simone Borelli from the group of Mondial in Barcelona. So it's very interesting what they do here. So it's a patient that has a 4-degree genovalgum that 3 months after a partial medial meniscectomy has medial pain. And 10 months after the first consult, failed conservative treatment, persistent pain with activity, pain stops, but then at minimal activities, again, medial pain. And as you can see in the MRI, we had this huge subchondral edema that is visible in almost all of the cuts. Cartilage looks fine. And there, as you can see, there is not much meniscal loss. But in spite of the genovalgum, patient has this bone edema that is unresponsive to conservative treatment. So what would you do in this elite athlete? So what would be, Manit, your choice here? Would you think of biologics?
Yeah, in a way. So we know a lot more about these BMOLs or bone marrow edema lesions now. And we know that they're a source of persistent pain. So there's been a lot of recent work and interest into this. And we understand now that it's like you've got this bridge which runs over a river. Right now, the bridge collapses onto the river itself. So you've got all this water underneath and you've got this floating bridge. So that's the subchondral bone with the cartilage on top of it. Now, that's why they keep getting pain. So if it's been 6 months and the edema is not going away, I think that's your time when you pull the trigger and you decide to do something for these patients. Now, in my practice, I've been doing something called, in a way, like micro drilling or microfracture. So what I do is under a C-arm or under fluoroscopy, I'll drill into this lesion from different angles. So what I found is that it actually leads to resolution of the defect. And you do protected weight bearing for a couple of weeks, and then you gradually get them back. The other more definitive option is to do a subchondroplasty. So drilling in, injecting a true fill or some other bone cement substitute into there, and that basically integrates into this meshwork there, and it raises your bridge back up again. So it takes away that pain from that subchondral bone. So I think that both those options are pretty good. Obviously, we haven't published too much about our technique of doing this, but I found that it really works well in professional players. It allows them to get back to sports faster. And even with the subchondroplasty guys, they do really well. So you've created a barrier. Before, we used to inject cement under here. Now cement is too hard. So there's a biomechanical difference between the quality of cement and a soft bone substitute. So cement cases used to fail because there was overloading that used to happen of the bone in that region. So once we started injecting this true fill or something like a bone substitute into there, it allows better integration. There's better capture of the bone, and it sets in over a period of time.
Great, thanks, Vanit. Dr. Santosh, what would be your treatment of choice here?
Here, I basically think it's because of the medial meniscectomy and the mechanical issues, and point loading is leading to the bone marrow edema. Even though we are not seeing a cartilage defect, there must be a breach somewhere where a subchondral breach, and then because of that, there is edema. So, and unfortunately, he's already in valgus. In spite of valgus, we cannot offer anything much. So, more we should think in terms of meniscal allografts or collagen meniscal implants on the long run, being young, or they must develop those osteophytes so that the point loading gets distributed. Then the symptoms might come down over time. That's my way of thinking.
Perfect, thanks. Sasinder, do you want to add something?
Yeah, I agree with Dr. Santosh because there is a reason why this is happening without any specific injury, especially after a partial meniscectomy. Even though we have some meniscal tissue over there and we have 4 degrees of valgus, but it's definitely not a normal physiological genovalgum. I think possibly it's less than normal, and part of the meniscus is gone. So that is one issue with respect to the alignment and the supporting tissues. On the other hand, we have a large lesion of subchondral edema, which is possibly not going to heal by itself. It needs intervention. I would go with retrograde drilling and PRP injection. I would keep my options. I would keep the prognosis guarded because of the alignment issue and the loss of the meniscus and warn the patient. I don't have experience with meniscal allograft, but possibly it will be in the treatment options in future.
Thanks, Asinder. And Fabiano, what do you think about this case?
I think at this time, this case is a perfect case for me for subchondroplasty indication. And a retrograde drilling, and I think I will fill with a bone marrow aspirate.
Perfect. Juan Pablo, do you agree with this? Would you do something else?
Yeah, I agree. I was worried about the amount of medial meniscus that the patient had, but yeah, you can see that there is meniscus, and probably this patient will need like a meniscal transplantation or something like that. I usually leave them in partial weight bearing for 1 month and see if that improves. But if we do all the things and they are still in pain, I think that the subchondroplasty would be a good option for this patient with BMAC or with PRP.
Okay, so well, Dr. Pirelli agreed with most of you, and this is what they did. They use a lip gem system. This is what Fabiano mentioned earlier. This is a sterile, one-use, like disposable system that is designed to harvest, process, concentrate, and transfer autologous adipose tissue, as you can see there. And they use the intraoperative X-rays, use a trocar into the lesion, and besides the drilling, they injected this concentrated adipose tissue. And fortunately, these are the images. This MRI is only 6 weeks post the procedure. So it's amazing how the edema is practically resolved. And the patient was able to return to sports 4 weeks after the procedure and has now 6 months of very good follow-up with pain-free back to elite sports. So regarding the cells used here, what do you think about Fabiano? Would you here use fat? Would you use umbilical cord? What do you think? Bone marrow aspirate? What do you think is the best option in these cases?
I think all of them. It's will feel this result. I think. Okay. I'd like to do. It's a great congratulations for this case. I think it's a unusual case, but congratulations for the result. I'd like to ask for all the panelists to if anyone has experience with not allograft transplant meniscus, but with collagen partial meniscus implant. Anyone have an experience? Because I don't have.
Meniscal implants, you mean, like scaffolds, right?
Yeah, like scaffolds. For partial
defects.
Yeah, thanks.
Maybe if any of you have used them, you can raise a hand. It seems like nobody has used them.
Yeah, I think in Europe, some countries have experience, but it's okay.
Yeah, Dr. Verdon and the group, they did some series, but apparently they didn't have the results as expected. I think ActiFit and many of those are no longer in the system available.
Yeah, and I think that's a good point, Fabiano, because you're treating the problem, but you have you're treating the symptoms, but there's a problem there. You lost a part of your medial meniscus, so that would be a good alternative. I don't know how good are those implants working, but I think that's an area in which we could continue working, because it's something that we don't have.
Yeah, I think in this case, this patient will be a perfect case for this meniscal implant.
Yeah, because we could suspect that if we don't correct the segmental defect of the meniscus, the edema could easily come back again in 6 more months. Dr. Santos, anything to add?
Yeah, but I just share the experience. 10 years back, we used to treat SPONK, something called SPONK, spontaneous osteomyelitis. Retrospectively, we went back and studied most of the MRIs, and we found most of them had root tears, medial meniscus root tears. We were not aware of picking up root tears then. So we had done drilling, retrograde drilling for those SPONK, and we had put them non-weight bearing for 6 to 8 weeks. They did do well, they did recover well, but retrospectively seeing them, they were all root tears. So now we are addressing the root tears. Now we know they are secondary contusions. So probably over time we'll also learn more. We have not yet understood the name completely.
Absolutely. Well, and in case any of you or the audience want to get deep into this topic, in the ISACOS booklet that has been out just now, 2021, this year, about orthobiologics, there's a chapter on Dr. Chala that addresses the use of cells and orthobiologics in SPONK lesions. So that's very interesting. Very few literature, not conclusive, but promising results. Okay, so let's go to our last case. So this is very simple. This is a very young patient, 17 years old, that had this isolated vertical tear of the posterior horn of the lateral meniscus. That will do a suture, a repair, of course, meniscal preservation. So my question to all of you is, would you think of adding any type of biological augmentation, let's say microfractures to the notch, or PRP, fibrin clots? What would be your routine in a young patient so that we in a tier that it's in the probably like red and red white zone? What would be your thoughts? So let's start with Juan Pablo. What would you say in this case? Do you use any augmentation, or you let biology alone?
So for an isolated injury in a young patient like this one, I would like to have a very stable repair, and I always do microfractures in the notch for have some bleeding, and I think that's enough in these cases.
Perfect. Manit, what do you think?
Yeah, I'm exactly the same. So when there's cases like this that I'm repairing, I would routinely microfracture the intercondylar notch.
Perfect. And if the tear, instead of being a 17-year-old traumatic, would be older patient, I don't know, I'd say 30, with a chronic, more degenerative tear, would you use any augmentation besides microfractures, or you always stick to microfractures to the notch only?
No, I've been pretty happy with the microfracture. So I think that the whole purpose is to get cells into that area. Even if you're putting in a fibrin clot and everything, I mean, this is just the way I believe. It doesn't have to be how everyone believes, but your knee is not captured in that space, in that moment in time forever. So there is going to be movement. There is going to be some disruption that's going to happen off the clot, even once you're putting it in. So I always feel the whole purpose is to get active cells into that area. And that active cells, the best way to do it is fresh active cells from a hole in the notch.
Great. Franco, do you agree, or do you tend to use more augmentations?
We don't use biologic augmentation in this kind of patients, these young patients. Sometimes in more older on chronic cases, we want to do a suture in the meniscus. Sometimes we use, but after surgery, 2 or 3 weeks after surgery with PRP.
Okay, so when you feel that you're extending the indication of your repair, right?
Exactly.
Dr. Santos, do you agree, or do you use
I do agree.
biologics?
Yeah, maybe add a vascular access channels where you pass in spinal needles from inside out for the posterior and outside in for vascular for the outer flap, and bone marrow venting or microfracture in the notch added to the repair. When we do not do an ACL, with an ACL it doesn't.
Fabiano, do you routinely use augmentation in your meniscal repairs, or when it's extended the indication or degenerative?
Yeah, I think in this case, I agree with Juan Pablo that stable suture is the best way to treat it. In chronic case or vascular zone, like white zones, sometimes I use PRP when the patient agrees with it, but we can use lipogenic salt, because I think there is a biological problem with this healing, so it's a good idea to use it.
Great, thanks. Anybody wants to add anything else or any questions to the panel?
Yeah, I would just add, in my practice, for such a young person, though the healing may be better, but because it is in the red-white zone and is into professional foot sports, such kind of patients and heavy workers, all of them go through 3 doses of plasma injection, starting from 2 weeks after the surgery. The general concept is, in addition, I also do the microfracture. The general concept is let the initial bleeding inside the joint do its job. And once it comes down, that usually happens like 2 weeks. I supplement with 3 doses of plasma injection. I don't do this for all patients. Maybe if it was a peripheral tear, I don't do the plasma injection because I expect the tear to heal anyway with a very good repair. And for heavy people, for heavy workers and professional players, I prefer to add up with plasma injection of 3 doses at 1 week interval.
Perfect. So thanks all of you for your contributions, excellent experiences. So we reached the end. This is the cases that we had prepared to know your thoughts about. So thank you very much all for your enthusiasm for giving this hour of time across the world to meet and discuss about biologics, and hope to see you again soon. Thanks.
Thank you very much, everybody, on behalf of WIROC and Bombay Orthopaedic Society. Thank you very much for participating.